a wonderful session. You're talking to some of the most knowledgeable people, not just in Indian country, although that should be enough, but actually in the country and in the world when it comes to kidney disease in our population. So we're very excited about that. So first of all, I'm going to introduce Gayle. She's an RN and a renal case manager at Zuni Comprehensive Community Health Center. She's received the Outstanding Nurse Award, the Albuquerque area, has been involved in publishing things, certified instructor in Tai Chi, that's very cool, and in falls prevention and healing touch. Good for you, those are all neat things. So we're delighted to have you here. Her co-presenter is someone who, for those of us who've been in Indian health for a long time, you all know Dr. Andrew Narva, Andy to his friends and everybody else. But Andy holds a very special place in our hearts. He was the IHS nephrologist for many, many years, retired from the Corps, and he went over to try to enlighten NIH as the director of the National Kidney Disease Education Program. But he's continued to actually be the chief clinical consultant for nephrology for IHS, still helps us out with kidney things. Really, nobody knows more about kidney disease in our population than this guy right here. And he was part of our vital signs work, along with other members present here, including Nilka Rios-Burros from CDC, on that wonderful kidney data that I presented this morning and many of you are aware of. Andy has already retired once, but he thinks he's going to do it again, and maybe this time for real. And so, end of the month still? Okay, so we in the Division of Diabetes, if you could just open that up, that'd be great. Just wanted to give Andy, that and a quarter won't buy him anything, but it is our undying gratitude, a certificate of appreciation, and it's original wording here. So the IHS Division of Diabetes wishes to express our deepest gratitude for your unwavering support and dedication to American and Alaska Native people. Your nephrology expertise and service have helped make possible the tremendous improvements in kidney disease that have taken place in Native communities. You're a true legend in your own time, and we thank you for your many years of making a difference. So with that, I'll turn it over to these two wonderful folks, and you're in for a great session. You guys.
Good afternoon. I'm glad to see you all here because it is 4:15 and it is kidney disease, so good for you. I've given many talks on kidney CKD and to lots of audiences of primary care professionals, and I generally run over and then there's no time for questions. So what I am going to do instead of that is to just answer questions in the beginning. These are the most common questions I've gotten. They may or may not be the questions that occur to you, but this is what people come up and ask me afterwards, and they tend to be very pragmatic, and I'll do my best to present them. I'm going to talk about the lab assessment of kidney disease, something about ACEs and ARBs, individualizing blood pressure goal, and then when we have 20 minutes left, I'm going to hand it over to Gayle Romancito to talk about another issue that people often have questions about, which is how to initiate discussions with patients about progressive kidney disease and its treatment, and she has probably as much experience as anybody in doing that. Over the last 12 years, she's talked to hundreds of patients with progressive kidney disease, and is part of her work at Zuni, which has a very high burden of kidney disease. So, first, lab assessment, urine albumin creatinine ratio. Should a trace of protein on dipstick be investigated? Yes, it needs to be quantitated with an albumin creatinine ratio. Is urine albumin, is the UA adequate for screening and monitoring? The answer is no, you need to quantitate it. The dipstick is a semi-quantitative tool, which means the result will depend on how concentrated the urine is. Does the UACR replace the need for 24-hour urine collection? The answer is yes. Nobody does 24-hour urine collections except for the evaluation of stone disease, and in some unusual situations. Because UACR, that's the albumin creatinine ratio, is a continuous variable, is the evidence of CKD based on a single result or a continuous upward trend. It needs to be, it's important to have a trend, and even to make the diagnosis of chronic kidney disease based on the presence of albuminuria, it has to be there for more than 3 months. How often should you monitor albumin and GFR in a person with kidney disease in primary care? That really depends. That's helpful, right? And so what is the first laboratory sign of decreased kidney function, and when should we refer to nephrology? I'm going to talk about that at the end, but oftentimes the first sign of kidney disease is increased urine albumin. So going into a little more detail, there are 2 ways of identifying people with chronic kidney disease, either decreased GFR, which is the upper one, or kidney damage, which can be lots of different things, but generally means increased urine albumin. So you can use, as you know, urine albumin results for screening and diagnosing and treating chronic kidney disease. It's usually the earliest marker for diabetic nephropathy. It's a really important prognostic marker. And we see lots of patients who have a GFR that looks normal, creatinine of 0.9 or 1, with 3 grams of albumin in the urine. That's a very, very bad sign. And if the albumin's going up, that's a bad sign regardless of what the GFR is doing. It's a really good tool for monitoring and guiding therapy. If you get somebody started on an ACE inhibitor and get their blood pressure down and their albumin creatinine ratio drops by 50%, you can tell them that it's much more likely their kidneys will last a lot longer than if they hadn't done those things. It's also a really good tool for patient education and self-management. If patients can understand an A1C, they can understand that the albumin in their urine has dropped from 500 milligrams per day to 250, or what that would be, or from half a teaspoon to a quarter of a teaspoon. Normally, we see very little albumin or protein in the urine. The current accepted normal level is less than 30 milligrams per gram or 30 milligrams per day. Protein in the urine includes albumin as well as other proteins, total protein, and it's generally less than 150. But the use of protein creatinine ratios and protein in the urine is going to go away for the most part. And the reason is that we're moving more towards standardized reproducible tests. And you can't standardize the measurement of total protein in the urine because it's such a mix of different substances. But urine albumin is a single protein, sort of, and that is being standardized. So in the future, well, what we'll do is be looking primarily, or maybe nearly exclusively, at albumin creatinine ratio. So how do we do this? You all order the urine albumin creatinine ratio. Most people order it, but they can't really explain what it means. It's based on the idea that the albumin and creatinine are excreted in the same ratio in a spot specimen as in 24 hours. So if you have twice as much urine albumin as creatinine in a spot specimen, it'll be twice as much in 24 hours. Why does that tell you anything? It's because the amount of creatinine excreted in a day is about 1 gram. So if you have twice as much albumin and creatinine in a spot specimen, then you'll have about 2 grams of albumin in the urine. So it's usually expressed as milligrams of albumin per gram creatinine, which is equivalent to milligrams of albumin per day. Did you see that microphone attack me? Okay, the 30 milligrams per gram is considered the cutoff, but that, I hate to tell you, is probably going to change. It may remain the cutoff for kidney disease, but we know, for example, that anything above 10 is associated with an increased risk of cardiovascular disease. Okay, what about eGFR? So why is the eGFR different for African Americans? It's because it's based on creatinine, and muscle mass is a slightly higher proportion of body weight than in non-African Americans. Is there a different eGFR calculation for Native Americans? There is not. How do I explain to my lab the importance of the need for actual numerical value of GFR and not just greater than 60? I'll explain what that's about, but if the estimated GFR is above 60, we still recommend reporting it just as greater than 60. And it's because of the variation in this equation. At what point do you need to get actual, which means measured GFR, and how is it actually measured? It's measured by injecting a marker into the blood and monitoring how quickly it's removed. It's done very rarely. It's basically a research tool, so we don't really do the measured GFR very often. Is eGFR part of the routine annual screening in a healthy population? No. How about spot urine for albumin? No. Is it a routine screen at the annual exam? It's no, but it's hard to avoid getting, anytime you draw blood, you're going to get a creatinine, and with that, you'll get an eGFR. How often should you monitor eGFR and UACR in a person with kidney disease in primary care? That depends. It depends on what's happening and other clinical aspects of their care. There's been a lot of emphasis on looking at eGFR to raise awareness, but it doesn't mean you should only look at that. Like every other lab test or biomarker, you have to look at it in the context of the whole patient. I'm going to skip cystatin C because it's not available to us. It's another way of measuring, of estimating GFR. So what is the eGFR? It's a way of using the creatinine to get a better estimate of true function. Because muscle mass varies in people, and creatinine is derived from muscle mass, we want to eliminate the kind of bias you might get from factors that affect muscle mass. And those factors are age, gender, and race. All of those things have to do with how much muscle mass you have. If you're older, you have less. If you're female, you generally have less. If you're African American compared to non-African American, you'll have a little bit more. So these equations back here, which, are the equations that we use to estimate kidney function. The variables are age, gender, race, and creatinine. It's just a way of adjusting for creatinine, the variation in creatinine. Now, it's an estimate, and so it estimates the measured GFR, and this may be a little bit in the weeds, but it's good to understand this. The performance measure for these equations is called the P30. And the way they decide how good this equation is to look at the percentage of estimates that are within 30% of a measured GFR. Okay? So in other words, if you have a patient with an estimated GFR of 59, using the current equations, they have about an 80% chance of being between 42 and 78. So it's a helpful tool. It's more helpful if you have a sequential number. But if you're just seeing a new patient and you have a solitary estimate of GFR and it's 55, before you say, by the way, you have chronic kidney disease and it's stage 3, you probably should look at some other things and maybe check it again, because they may actually not have that. So what this figure shows is the estimated GFR on the bottom and the measured GFR minus the estimated GFR on the vertical. But basically what it shows you is this is the range of plus or minus 30%. So in other words, if you have an estimated GFR, as you go here, as your GFR goes up, as the estimate goes up, plus or minus 30 gets really big, right? So the reason that we recommend still that above 60 be just recorded as, not recorded as a number, is because anything out here above 60, it's a huge variation. And lots of little things can affect your creatinine on any given day. If you had a steak last night, your creatinine is going to be higher. You know, if you exercised hard, your creatinine might have gone up. There, you know, and if you took Motrin 2 days ago, you might go up. So we don't emphasize the importance of the higher GFRs. As GFR gets lower, that range gets narrower, and it's a more reliable tool. Okay, what about diagnosis? Is there a way to know if CKD is caused by diabetes or hypertension that a patient already has? Well, first of all, the only way to know for sure what someone has is to do a biopsy. And in general, if someone has had diabetes for a long time and they have proteinuria and they have retinopathy, then it's likely that their kidney disease is due to diabetes, and most nephrologists would not do a biopsy. But but even so, we're still investigating how reliable those sort of predictive tools are. Hypertension as a cause of kidney disease, a lot of people question whether there actually is a thing. Hypertension in the absence of any other underlying disease. In some ways, much of that might relate, because it's often a diagnosis that African Americans carry, it may relate to genetic variation that is associated with increased susceptibility to kidney disease. So how can you differentiate diabetic kidney disease from another kidney disease? A biopsy is needed. Can one say that kidney disease is caused by diabetes if the patient also has hypertension along with the diabetes? That doesn't necessarily prove anything. If someone has 730 milligrams per gram of albumin in their urine, does this mean they are currently having acute renal damage, or is this damage that occurred when they were uncontrolled? It doesn't work that way. Just like chronic kidney disease, acute kidney injury has a pretty well accepted and consensus-defined diagnosis, and it's based on a certain increase in creatinine or eGFR. Okay, so as you all know, there is a lot of diabetes in this country, especially in the people we serve. About a third of people with diabetes nationally have evidence of kidney disease, either albumin in their urine or decreased GFR or both. The natural history of this is that initially, this is the GFR up here, and this is the albuminuria. Initially, GFR goes up. It's part of having hyperglycemia. And by the way, along the bottom is length of time you have hyperglycemia. It goes up, and then it gradually comes down. And it's at the point at which it passes back towards where it started is where proteinuria starts to increase. So at this point is when there's lab evidence of kidney disease, because albuminuria is increased, but GFR hasn't decreased. But it actually has decreased from up here, but you wouldn't know that. So that's why it's often said that albuminuria is the first sign. And in our patients, that's often true, although we often see them not close to the time when they're diagnosed. Then over time, the GFR drops and the albuminuria increases until the GFR is so low that not much albumin is being filtered. However, that's almost like a stereotypical natural history. Albuminuria can get less. You can have decreased GFR without albuminuria and still have diabetes. Probably some of you have seen patients like that. I certainly have. And the other issue is that there are probably many different kinds of diabetic kidney disease. It's not just one lesion. And probably in the future, we will probably do more biopsies on people who have diabetes and kidney disease for a lot of reasons. One, to find out exactly which kind they have, but also to try to, as we develop better therapeutic tools and ways of identifying who responds to which drug, that might help guide therapy. You all must have patients, some of whom have responded really nicely to ACE inhibitors, and other people who don't get touched by it. Why is that? So maybe that will help us. So hypertension. hypertension causes kidney disease, and then kidney disease makes hypertension worse. And so it tends to be a spiral, and it's hard to know which comes first, but they exacerbate each other. So, should patients with CKD ideally have blood pressure less than 120/80? Less than 140/90? That's a good question, which I'm going to talk about because a lot of people worry about this. Is there a risk of hypoperfusion, inadequate blood flow to the kidney when you're controlling blood pressure to 120/80? Yes. And the role of diuretics. So, blood pressure is not well controlled in people with CKD. You can see that in general, only about 50% of people have blood pressures controlled to less than 140/90. This is in the general population. Of course, it's better in Indian health. We know that. Everything's better. And the goal, people are very confused about the goal. There have been iterations of what's called the JNC, the Joint National Commission, on setting blood pressure goals, and each one seemed to set different standards, and depending on the strength of the personality of the people who are in these sort of eminence-based, not evidence-based, eminence-based groups, they would invent new classifications. I was lucky enough to be on JNC 8, which I'll talk about in a minute. Now, there have been some studies that have looked at blood pressure control in people with diabetes. In ACCORD, one of the parts of ACCORD was to have two different blood pressure goals. One was a little bit less than 140, and one was about 120. And this just shows that they actually achieved separation between the two groups in quite a large number of patients. And those patients were followed, and it turned out that that made very little difference in any of the outcomes of the study, except perhaps in non-fatal stroke, which is the upper right box. The other ones, the lines are essentially the same. The conclusion from ACCORD was that targeting a lower blood pressure of 120 systolic did not reduce the rate of fatal and non-fatal major cardiovascular events in patients with high risk with type 2 diabetes. And however, those patients had significantly higher rates of adverse events associated with the antihypertensive treatment, such as hypokalemia, elevations in serum creatinine. Okay. There was another study called the ASK study, which looked at higher and lower blood pressure and progression of kidney disease. Basically, very similar goals, 140 and in this case 127. And in the overall group, there wasn't much difference. If you separate the two groups into people who had proteinuria and didn't have proteinuria, in the group that didn't have significant proteinuria, there was no difference. In the group that did, this is more than about 220 milligrams per day. There was a difference in outcome, but it wasn't large enough to really draw a strong conclusion. And this is something important as we go into the future, is it's really important to distinguish between people who have significant proteinuria and kidney disease and people who don't. So those are the main studies, the high-quality studies that we based our recommendations in JNC 8, which just came out a few years ago, that recommendation came out, I think, 3.5 years ago. And we basically recommended for people with diabetes 140/90, and for people, older people who didn't have diabetes or kidney disease, we actually said 150/90, which is a lot closer to what the evidence supported. What was unique about JNC 8 is actually we followed the guidelines of the Institute of Medicine on the guideline on guidelines, and we didn't go beyond that. Okay, so what's happened since then, and why have you heard so much about 120/80? Well, the sprint has happened. This is the only significant study that's occurred since JNC8. And SPRINT looked at systolic blood pressure goal of 120 versus 140. And in fact, this looks just like the Accord. They achieved similar kind of separation, so they did a great job. They found a big difference in the primary outcome, which was cardiovascular outcomes. And in fact, they stopped the study because it was so impressive. And then, as a result of that, the new guideline came out from the AHA and the ACC, and this has been widely promulgated. And they recommended a blood pressure goal of 130 over 80 for pretty much everybody. Okay? Now, no one tested 130 over 80. They tested 120. And the other issue is they made this recommendation for diabetics, and there were no people with diabetes in SPRINT. They were excluded. So that was pushed very strongly by ACC and AHA. But there was pushback from the generalist community, and in fact, this editorial really gets at the point of overreaching based on one study. And the ADA also did not recommend this new guideline and recommended 140 over 90, acknowledging that for people in certain risk groups, you could consider a lower blood pressure goal. Okay, so what is the issue with lowering blood pressure? I mean, if a little blood pressure lowering is good, why isn't a lot better, right? So this shows in Accord and in SPRINT the what they call incidence of kidney disease, which basically means an incidence of decreased GFR in both studies. And this is Accord with a lower blood pressure goal, and this is Accord with the higher blood pressure goal, and this higher blood pressure goal in SPRINT and lower blood pressure goal. And in both studies, there was a significant increase in incident chronic kidney disease, which meant a drop in GFR. Okay, so where are we now? So we know that epidemiologically, new kidney disease is higher in people with type 2 diabetes than, from the study rather, we know that incidence chronic kidney disease is higher in people with intensive blood pressure lowering. And we know epidemiologically that chronic kidney disease is associated with risk for cardiovascular disease. However, we don't know if the chronic kidney disease, with the decreased GFR that you get with aggressive blood pressure lowering, increases the risk of cardiovascular disease. Maybe it's just a side effect of the drug, but we don't know that answer. So what we need now, and I know the NIH is funding mostly secondary analysis of the data to decide whether the higher risk of this drop in GFR, the incident chronic kidney disease with intensive lowering of systolic blood pressure, is outweighed by the expected reduction in cardiovascular disease and all-cause mortality. So lowering blood pressure in general decreases the risk of cardiovascular disease, but it increases CKD, and CKD is associated with increased risk of cardiovascular disease. So it remains open, and that's why it may be a little bit of a leap to take the results of the studies and just say, well, everybody needs to be brought to this level. Okay? And I think the IHS guideline remains at 140 over 90. So, you know, I think the goal is, that was endorsed by JNC8 is been sustained by other groups. The sprint data I showed you, regardless though of whether you try to get to 130 or 140, controlling people who have uncontrolled high blood pressure is a major challenge. Although again, like uncontrolled diabetes, I think is a smaller and smaller problem in IHS and other well-organized diabetes care delivery systems. At any rate, just because you read it in the annals, or you read it in New England Journal, or you read it someplace, doesn't mean you can take that and run it and apply it to everyone. And this isn't true just for this blood pressure guideline. It's true for almost all clinical guidelines. And again, the other part of this is that many clinical guidelines now are based on very discrete laboratory tests, and a lot of those laboratory tests have a lot more uncertainty associated with them than you might think, like the estimated GFR. So that's not really built into these guidelines, which are often meant for simple and easy dissemination. So I think there are lots of guidelines in IHS, but I think they all remain within the range of what is really truly evidence-based. Okay, what about addressing resistant hypertension? There's really not all that much blood pressure that is truly resistant. And most times, and in most of our patients, it reflects inadequate diuresis. People with diabetes are volume overloaded, and if they're not controlled and they're not on a diuretic, the answer is to use a diuretic, or to be sure that they're salt restricting. Salt is an incredibly powerful drug that can overcome the advantages of blood pressure control for the patient. Use of ACEs and ARBs. Is there a lowest effective dose of ACE or ARB that will give the kidney benefit? It's never been tested. Almost all the studies for preventive use of these drugs is based on a fixed dose, and it's not really adjusted. At what point with creatinine elevation or does the ACE or ARB become less beneficial and should be discontinued? You know, empirically, if the GFR drops by more than 30%, then you should probably stop it. But the fact is that a small drop in GFR is actually a sign of hemodynamic effectiveness of the drug and may predict benefit to the patient. When you stop an ACE or ARB, what should you use? You can use any of the usual things: beta blocker, calcium channel blocker, diuretic. If a patient on losartan or lisinopril has hyperkalemia, do you decrease the ACE or ARB? Not necessarily. Most people can live with a little bit of elevation in their K in the low 5s, especially if they're at high risk. But the other thing you can do is if you give them a diuretic, a loop diuretic, for example, that'll lower their potassium. If they have acidosis, if their bicarb is less than 22, you treat that. By treating the acidosis, the potassium goes back into the cell and the serum potassium drops. What are the risks and benefits of treating concomitantly with ACEs and ARBs? Don't do that. Recommendations, what about, and this happens a lot in our patients, you've increased the ACE or the ARB to the max and you still have high-grade albuminuria. There are not a lot of good answers to that. I think maybe making sure, giving the patient an SGLT2 inhibitor may be a really advantageous thing. It does lower albuminuria, and it's one way to try to help the patient. But once again, we see lots of patients with massive albuminuria, and I'm talking between 10 and 20 grams per day. And regardless of what else is going on with that patient, if the cause of their albuminuria is diabetes, there may be nothing that really has much benefit for them because most of the damage is already done. Okay, what are issues? Yeah, am I close, Gayle? How many? I still have 5 more minutes, right? Okay. Okay. What about other issues with ACEs and ARBs? As you know, common adverse effects are hyperkalemia. You should avoid using both ACEs and ARBs. You should avoid potassium-sparing diuretics. For people who have a cough with an ACE, you can try an ARB. Rarely people have angioedema, although the first patient I gave the drug to had a horrendous case in Albuquerque. I remember it scared me a lot. And again, you can tolerate about a 30% increase in creatinine, or 30% decrease in GFR. Any situation where a patient has renin-dependent disease state, in other words, where someone is volume depleted, it increases the risk of acute kidney injury. Patients with congestive heart failure, volume depletion, overdiuresis, or cirrhosis, use these drugs really, really carefully. And NSAID treatment also makes things much worse. Probably the single most important thing we could do now, and this is a tough one with the opioid epidemic, is to use NSAIDs even more carefully with our patients, because the kind of acute hemodynamic injury that we get when people are on ACE inhibitor and a diuretic and NSAIDs, and then they get a little sick and become volume depleted, those insults accumulate over time and can really result in significant loss of permanent loss of kidney function. Who's at high risk? This sounds like our patients with diabetes or hypertension together, multiple comorbid conditions, including renal artery disease, liver disease, congestive heart failure, recently discharged from the hospital, and multiple drugs which affect renal hemodynamics. This is a video that I'm not going to show, but it's available on our website. There's one version, it's 2 minutes, and explains renal hemodynamics and how these drugs affect the patient. And there's a version that's meant for patient education as well. Should you use them in combination? Again, no. There's 2 major studies. They both showed the same thing. No difference in cardiovascular endpoints and more adverse effects. That's one, and this is another one. They were both stopped before they reached the end of the trial. What about prognosis? Should a person with 1 kidney be on a low-dose ACE inhibitor for renal protection? There's nothing to support that. Be screened annually for UACR? Yes. By definition, someone with 1 kidney has chronic kidney disease, so they should be followed. Do you recommend ACE or ARB prior to elevated protein in the urine? There's no evidence, even in diabetics, that giving an ACE or an ARB to someone with less than 30 milligrams of albumin per day who's not hypertensive will get any benefit. When should I initiate referral to renal? I'll talk very briefly about that. And what should be ordered to work up patients? So it's important to follow the urine albumin. This just shows the prognostic implications of having the higher your urine albumin at diagnosis, the higher your risk of death, dialysis, or loss of kidney function. And this just shows, and this is schematic from a study called RENAL, which shows that the greater the response to an ARB in decreasing albuminuria, the better the patient's likely to do. So if you have somebody who's normotensive and you've started them and they have proteinuria and you started them on an ACE, and you say, well, their blood pressure is normal, they're on an ACE, why do I even have to check it anymore? The reason is you want to look at the response, and you might even want to titrate the dose up to see if you can get it any lower. Other things you can do to reduce urine albumin or lower blood pressure, reduce sodium intake, diabetes control, reduce weight, even if they're not diabetic, reduce excessive protein intake, and smoking cessation. Who should you send to a nephrologist? Use your judgment. There's no absolute level of EGFR where you need to send patients to the nephrologist. If you're not sure what's going on or you don't know what to do, like you use nephrologists the same way you use other kinds of consultants. There's a form, a fillable PDF that one page that you can use for referrals. It'll make sure that when your patient goes to the nephrologist, they'll have the information that they need. And the goals for population management in chronic kidney disease, which are to reduce the need for renal replacement therapy, are really pretty much good diabetes care. If you look at all these things, there's nothing there that isn't part of good diabetes care, except the last one, which is to educate the patients about kidney disease and its treatment. And we have some materials from our program, but I think I really wanted to share my time with Gayle because she has vast experience, and I want you to know that she is a resource within IHS who really can talk to how to educate patients. There's a lot of materials out there. A lot of them are not very helpful to our patients. So I'll turn the podium over to Gayle.
Good afternoon. Let me see. So the talk about chronic kidney disease on a nursing perspective is rather pretty much the same thing. If you've come across patients, we're getting the referrals. Some of them even cry when they hear the word Dr. Narva or now my name. It's like, what does that mean? And a lot of the people back home have been taken care of by their grandmas, their grandpas. That's been, Dr. Narva would be their nephrologist. So and that equates with dialysis. So the fear is still really prevalent. And so when patients come to my office, I want to get a feedback of what they know about kidney disease. And so we want to be able to dispel any myths. CKD does not mean dialysis or death. A lot of people, because of their personal experience with loved ones, they feel that, getting referred means that they're eventually headed towards death. But you want to dispel the myth that early referral is important because that means you have a more longevity of maintenance care and to start initiating the discussion of the disease process. Kidney disease is asymptomatic. You don't know that you have the symptoms until it's too late, right? And so a lot of people still have that perception, like, like they see more the dialysis patients when the skin starts to discolor. And when people say, I have kidney disease and they look really strong and healthy, it makes somebody think twice. And so you want to be able to dispel that CKD does not mean death or dialysis. And then number 3, you want to just explain the disease process. A lot of people really don't know what the disease process is. So, we'll come to a one-to-one educational session because back home, confidentiality is an issue, and I would have CKD classes, and I would invite all my stage 3s or my stage 4s and 5s, GFR of less than 30, that really need the early education, but because of confidentiality or just saying, I'm not going to go to her class because they know I'm going to have kidney disease. They know I'm in that direction. And so I've just learned to do a one-to-one discussion. You want to be able to explain the risk factors, just some of the facts about CKD. That, age is one of the risk factors. We're not getting any younger. And family history. If you know of somebody, or they pretty much will have an idea that there's family members involved that have been affected with CKD, so that they already have their perceived kind of notions of what to expect. Native Americans, as much as we have our native pride, it's in our genes, so we are at risk for kidney disease. And just being a little bit on the fluffy side doesn't make things any easier, so you kind of have to explain this to your middle-aged or elder patient, and they kind of chuckle at this. It's like, these are just some of the risk factors that we can't change, and we haven't even talked about diet and exercise. And so just be straightforward with them, and you want to be able to just have this ongoing education and create that rapport with your patient. They are scared, and some people will not, I've had patients avoid me in the hallways or out in public because, they're afraid to hear the bad news. But you just want to be able to kind of be patient with them. And so as a public health nurse, because I will hold so many sessions and I go do public health service announcements to say, hey, this is my class, and I would have maybe out of 40 to 50 people that really need the education, I would have maybe 2 that would show up. And these were people from the community, either caretakers or somebody that needed community hours to learn about CKD. And so I'm like, how can I, as a public health nurse, try to capture my patients? And I've been creative in terms of doing my outreach. So I would go to the senior center, and that's where you have some of your patients that you would see, and you would talk to them in a general setting, and therefore their disease process isn't really, it's less threatening. I've gone to the detention center and talk about the risk factors, and that it could be some of the nephews and uncles, that are in jail whose family member is at the senior center with CKD. Home health centers, health fair is a really big ones of just doing outreach, blood pressure screenings. We've done collaborated with the Healthy Lifestyles during their basketball co-ed games, and we would just do their blood pressure screenings, and we would actually get a few patients with elevated blood pressures, and we would just follow up with that. And so just being creative in that sense, so it's less threatening. I've learned to use visual aids, having to explain all the statistics that was up earlier in a patient-oriented way. We've had, I've used the little coffee filter analogy, and just having to explain the disease process of having to explain proteinuria, to say, if you can just visualize this coffee filter and just make a little pen mark on your paper, and just imagine, so many nephrons, so many blood vessels can fit in that pen mark, and explain the disease process of your GFR and proteinuria. The patient at the end of the discussion is like, wow, that makes so much sense, and how come the doctor never explained this to me? It's like, well, that's because the doctor also has to go over your diabetes and your asthma and all the other health problems. And so just being able to use those kind of visual aids would help understand, and most of us are visual learners at some point. Would kind of makes the disease process or to understand a little more helpful crossword puzzles, CKD bingo, and playing Jeopardy are one of the other ways to do patient education in a comfortable atmosphere. I've developed a CKD bingo. One column was like about myths and facts about CKD, nutrition, another column on medications, and then another column on nutrition, and then another column on side effects and complications. And by the third game of this bingo, people are holding a discussion of saying, "Oh yeah, 1 in 9 adults have CKD and they don't know it." It's like, "Oh yeah, that's true." And it'll say, "Hey, so and so had this," and it goes, "Oh yeah." And so it's just surprising how people naturally open up, and you end up having an open discussion that you would not have if you were to do it in a lecture form. Nobody likes to speak up in front of people and share their story, right? But this was one way where this was kind of an engaging activity. And of course they said, "I got bingo, where's my prize?" And I'm like, shoot, I've yet to work on the prizes. But I said, well, knowledge is power, so that's your incentive. And so you just want to emphasize the prevention and maintenance care, diet, exercise, lifestyle. And so when you tell your patients, if you can manage your diabetes, you can definitely manage your kidney disease. It's like it's no different. And so that's pretty much the emphasis. And like I said earlier, referral, you've got that 10, 15 year of reinforcement. And I think it really pays off at the end. And you can tell how, or at least for me, how many patients there are out there that have really been referred early. They know what to do, and so they manage themselves a lot better. I've had a patient that was in their maybe late 70s, would naturally just come in and say hi, and you'd never know they had kidney disease. Just a healthy, strong, vibrant man. And he would say, "You know what? Having kidney disease isn't so bad. You just have to do everything in moderation. Just eat in moderation, even have a little alcohol in moderation, and even sex in moderation." It goes, "All right, and I asked this individual, "Can you be my patient spokesperson out there?" Because that's what we're trying to emphasize as nurses is, everything should be in moderation. And sometimes we kind of tend to do the extreme of saying, "No, you can't have that. No, you can't have this." And it leaves the patient going home discouraged, right? And then the heart-to-heart discussion, once, and you would hope that once your patient has known you for quite some time, that their disease process is naturally declining. Maybe just the natural course of it, or maybe because of uncontrolled diabetes, it comes to that point where they now enter stage 4 or 5. And stage 4, when your GFR is about less than 20, that you start initiating the conversation, and people still have time to be able to talk about dialysis and to have to start the discussion, and this can be very sensitive. I normally don't do this in health fairs because then nobody comes to my booth. And so, having that one-to-one talk, encourage early access, early referral for transplant, and just continue to emphasize the manage of diet and exercise. And this is when, patients start to open up. It's like, I'm a little scared. There were times I had one individual that told me and Dr. Narva, it's like, "Well, do you want us to tell your family?" He goes, No. My family doesn't know that I see you, Dr. Narva. It's like, oh, okay. So some people are really private. I mean, they're open to their to see their cardiologist or their diabetes doctor, but for some reason, it's like when it comes to kidney disease, it's still a private matter. And so just having that early discussion and just to say, hey, you know, it's okay, you're not alone, and you don't have to, you know, hide everything, and just encourage them to tell family members, because they're going to be the most important support system when it comes down to having the talk about dialysis. Number two, having a family meeting, you know, to just, like I said, open the discussion to involve family members. Sometimes having a guest speaker who is on dialysis, invite them to the class, or arrange a tour of the local dialysis unit. And we've had the privilege of having patients that are headed towards dialysis to say, yeah, I want to be able to see exactly what's going on. Sometimes they'll hear stories from relatives saying, you know, you do not want dialysis, this is not good for you, but each person is different. And so you know, having an actual tour of the unit allows them to see hands-on what it entails. And then arranging a one-to-one office visit with another person on dialysis is really, I think, beneficial. I've had a couple of patients come up to me and it's like, well, how would you know? You've never had kidney disease. You've never had, you know, you're not on dialysis. What gives you the right to speak that? And it's like, you know what, you're right, but you know, I can get somebody for you, arrange a one-to-one visit, and this is, you know, and I've had patients come up and say, you know, you and Dr. Narva have helped me so much, and interestingly enough, these were some of our most resilient and stubborn patients that were very resistant to accepting their disease process until after going into dialysis, that they said, oh, all these educational classes or the education you provided has really helped me, and so I'd like to pay it forward, and if you know of anybody that you want me to talk to, please let me know. And so I've taken up those offers. One who's on hemodialysis, I'll call them up. It's like, hey, so-and-so is, you know, I won't tell the patient that, I'll let them meet on the day of the appointment date just to maintain that confidentiality. And so I think that makes it meaningful for the patient to say, hey, I know you from the community. I didn't know you were on dialysis. And it's like, you look so strong and healthy. How'd you do it? So they have this conversation going, and I think it also empowers the person on dialysis to say, hey, it's not so bad. So it becomes a win-win situation. And then dialysis, you know, it's a transition in life. You want to be able to provide encouragement, empowerment, and guidance and support. And you want to be able to determine the family dynamics. And sometimes the person that's ready to go into dialysis is the breadwinner, is the, you know, that keeps the family together. And if they haven't told family members, you can just imagine what kind of support they'll have. And we've had one instance where a family member had not decided which modality they wanted. They ended up in the ER, and they ended up on dialysis after treatment, and months later they were angry because it's like, you know, why'd you guys have to put me on dialysis? I didn't want any of this. Now I'm suffering, nobody's taking care of me. And these are just like raw emotions coming out, and they can get very sensitive and touchy. And based from that experience, you know, as much as it's hard to discuss about death and dying, these are some of the topics that I will bring up with our patients. It's like, okay, you know, some of us and most of us are selfish in some way, that we don't want our loved ones to go on dialysis, and if they choose not to have dialysis, you know, who knows what their life expectancy is. And so I think we want our loved ones to stay with us a little longer, but we fail to see the patient's point of view, you know, who's going to be taking them to dialysis, who's going to be taking care of them on their sick days. And this is something that I've brought up with the family. And so it's not easy, but it also needs to be addressed. And so just having to bring those discussion kind of brings it to life of like, oh, I never, you know, considered that, and you know, and it's just kind of, you know, you'll shed tears, and this is where, you know, acknowledging your birthdays, using your sense of humor, poems to deliver a message, and to be a patient advocate. You know, I had, you know, a couple of poems where I would just say, hey, you know what, if you're undecided, you know, everybody else is doing dialysis, but maybe peritoneal dialysis might be for you. You're such an independent person, you know, and so think about it. And so, you know, there's just poems that I would gather, and I don't think I have. I just wanted to share one of them, and I'll just give them out. I'll give this poem out, and it makes them think, kind of. But it says, "It's impossible," said pride. "It's risky," said experience. "It's pointless," said reason. It's like, give it a try, whispered the heart. It's like, okay, you know, it makes, I don't know, it just makes the patient a little more receptive, and they can take it home and reflect on that. And just a sense of humor. We had one individual who was contemplating, he was a silversmith, didn't want to get his access yet. And he goes, you know, and I was teasing him, a very traditional man. It's like, you know what? You keep doing your morning prayers. You keep giving your offerings, because that's also what's holding you to this point. And he just